so much for the invitation to come and speak at your conference today. My name is Stephanie Kerkvliet. I am a pediatric nephrologist at the Children's Hospital of Philadelphia, and I take care of children who have kidney disease and many of whom need transplants. I'm excited to share with you this presentation where I'm going to talk about common reasons that children need kidney transplants. I have nothing to disclose. So throughout this presentation, I'm hopeful that you will gain an understanding of normal kidney function and how we measure that. I'm also going to review some of the most common reasons that children need kidney transplants and also give a really broad general overview for kidney transplant evaluation process in children. So we'll start by talking about normal kidney function and structure, move into how we look at that function, particularly using a measure of kidney function called estimated glomerular filtration rate, or eGFR, and how we use that to define different stages of where you are, where a child is in chronic kidney disease. Then we'll move into a list of different kidney diseases that can cause kidney failure in children where they may need a transplant. And finally, we'll go over that transplant evaluation like I had discussed. So let's dig in and just talk about normal kidney function. So the main job of the kidney is to filter the blood within the body. And by doing that, the kidney removes excess fluid, so it's making urine. As it filters the blood, it balances electrolytes and makes sure that everything is well balanced with regards to acid and bases. And then it also removes toxins, and those will often get excreted in the urine. So where are the kidneys? Just talking about normal structure. Most people are born with two kidneys, and they're located sort of in the back, protected by that rib cage there. And then you have these long tubes called ureters that connect the kidneys to the bladder. And then out of the bladder, the urine flows through something called the urethra out into the environment. So this is a beautiful image from the National Kidney Foundation that I think really beautifully puts together how the kidney function and structure are related. So in this red tube here, that's the artery that's carrying blood to the kidney. So the heart is pumping blood to the kidney. Within that red tube, you see some red blood cells, those red dots, as well as waste that need to be excreted into urine. Those are the yellow dots. Those go into the kidney. The kidney has tons of these tiny little microscopic filters that we'll talk about more in just a second. And in those microscopic filters, it will help get rid of those yellow dots, the waste into the urine. And then the clean blood returns to the veins here, which are these blue tubes, and back up to the heart where the process goes again. The kidneys are constantly cleaning and filtering the blood. So digging into this glomeruli, this is going to be really important to understand the microscopic structure as we talk about some of the different diseases, some of the different kidney diseases that some children need transplants for. And so the microscopic filter unit of the kidney is called a nephron, and that's made of these little tufts or sort of groupings of these microscopic tiny little blood vessels. And the blood moves through those, and those blood vessels called the glomerulus, this little tuft here, that's sort of like a colander or a cooking strainer that you might use for draining pasta, for example. And so as the blood moves through there, ideally those filter units are working to let the waste sort of go out and to keep the blood cells and the proteins and other things the body needs in the blood. Now there's a lot of fine tuning that can happen through these long tubules of this filter unit called the nephron here. But in general, a lot of the important work of the kidneys happens in these little groupings of blood vessels called the glomeruli, or the filter units. And it's really amazing if you look at the kidney under a microscope, that's what this pink image is showing, you can see these tiny little tufts, or the glomeruli, these filter units here that are doing the job of filtering much of the blood. So that's the main job of the kidney that we talked about. It's removing excess fluid, it's balancing your electrolytes, getting rid of toxins as it makes the urine. But the kidneys have a lot of other really important jobs. So the kidneys are important in making and responding to hormones that regulate blood pressure. They secrete hormones that tell the body to make red blood cells. So if your kidneys don't work, you might have anemia. It's really important in holding on and balancing those nutrition, those proteins and vitamins and everything that help children grow. And the kidneys are also really important in vitamin D metabolism, which tell the body to hold on to calcium and phosphorus and to build strong bones. And so, if a child has kidney disease, it can affect so many different parts of the body system. So, now that we've reviewed the general function and structure of the kidney, let's delve deeper into how do we measure if the kidney's working or not. So, when I see a child in my clinic, there are a few different ways that I'm looking to assess their kidney function. Most basic, I'm looking at the child and doing an exam. And some of the things I pay particularly close attention to are the blood pressure. Many times, children with kidney disease will have high blood pressure. So, we're watching that closely, and I'm watching their growth chart and their weight gain really closely as well. We talked about how one of the main functions of the kidney is to make urine. And so it makes sense that if you want to see if the kidneys are working, you can look at the urine and particularly look to see, is that urine, does it have extra protein or blood in it? Because that might be a sign that the filter units of the kidney aren't working so well. Another thing that we will often do is take blood work to look at blood tests, and we're looking at the electrolytes as well as some types of waste product called creatinine. And I'll talk more about that in a second, but creatinine is a waste product, often of muscle, that we can look and see how well the kidney is filtering. Cystatin C is another molecule that we can look at in the blood to help us predict kidney function. And then also blood counts. So looking at what the red blood cell counts are looking like, and some other marker is another marker of kidney function. We can sometimes get a kidney ultrasound or other imaging of the kidney, and that's a good way to look at the structure of the kidney. Ultrasounds don't tell quite as much information about the actual function of the kidney. Um, but sometimes if you're looking at the structure of the kidney, you see some big cysts, or that tissue, the parenchyma, that meaty part of the kidney is really thin, that sometimes gives you a hint as to if the kidney is working well or not. And then finally, sometimes we need to do a kidney biopsy, which is a minor procedure where we take a little bit of the tissue of the kidney and we look at it under the microscope. So I want to dig in and talk more about these blood tests here. So with the blood tests, particularly with creatinine and cystatin C, we can use those markers to calculate something called an eGFR, which stands for estimated glomerular filtration rate, or how well are those filter units of the kidney filtering? How well is the kidney working? Um, so to calculate that, we take some results from the blood work, creatinine, and sometimes cystatin C. You don't always need that to calculate it. You need to know the child's age, if they're male or female, and their height. And you plug it into an equation, which I'll show you on the next slide, and it gives you a number. The number, if it's greater than 90, that's normal. And if it's less than 90 for a prolonged, at least 3-month period of time, that fits into what's called chronic kidney disease or longer lasting kidney disease. And there are different stages of that. First, let me show you how we actually calculate the eGFR. So really, there are online calculators. Sometimes they're integrated into the lab or the electronic medical record, but I know a lot of parents like to calculate it themselves based on lab work. And so there are many websites. Truly, if you just Google this CKID U25, that will usually pull up an online calculator that you can calculate your child's GFR. I included a link here that you could also click on, and the facilitators of the conference can also get that to you if you're interested, but it's also not your responsibility. Your kidney doctor will be watching these really closely. So what comes up is just some prompts where you would put in your child's age in years. There are options for male or female. Then you would put in their creatinine. Be careful, you got to make sure that the units are accurate. In the United States, creatinine is usually measured in milligram per deciliter. Just want to make sure those are right. Their height, usually you put it in centimeters. And then sometimes if you have a cystatin C, include it. If not, you don't need it. And it will come out. So in this example, with this 3-year-old girl, her creatinine is 0.3 and she's 95 centimeters tall, we would say she has a normal GFR. Her kidney is functioning normally. So If the eGFR is lower than 90 for a prolonged period of time, then a child's classified into chronic kidney disease. I will also say that children are born with kidneys that are a little bit immature. And so we don't expect babies' kidneys to be full functioning adult kidneys. And so there's a lot of nuance and specificity to this that's important to talk with your doctor about. But usually I start classifying children within these stages of CKD after the age of 2. Because around the age of 2, then I would expect their kidneys to be functioning at a good level of maturity. So say I have a 3-year-old and her creatinine is greater than 90. That's great. I would say that as long as her function is normal, if she has an abnormal structure, then she might have stage 1 CKD. So stage 1 is normal function, but usually abnormal structure. So that might be a child who's born with only one kidney, but that one kidney is working excellently. I wouldn't expect any problems. That would be stage 1 CKD. And that progresses down. If eGFR is lower, you can go into this mild, stage 2, a little bit more moderate, stage 3, if the eGFR is between 30 and 60, stage 4, and then finally stage 5, if that eGFR is less than 15. That's really severe kidney disease. And at this point, thinking the kidney is likely failing and heading towards needing dialysis or kidney transplant. It's important to note that not all children, if they have CKD, will progress to stage 5. Sometimes a child has stage 2 or 3 CKD, and they'll have that their whole life, and it's really important to protect their kidneys and monitor their kidney function as they grow. But not everyone will progress to stage 5 CKD if they have kidney disease as a child. I typically think of stage 2. Most children won't have too many problems with that. In stage 3, sometimes we're starting to think about if medicines might be needed, particularly to help with blood pressure or electrolyte balance. Stage 4 is more severe, and at this point, I'm often having conversations with children and their family about if they might need a transplant in the future. And then stage 5 is really closely monitoring the kidney function and making sure the child is safe, or starting some kidney replacement therapies like dialysis or transplant. Um, this is really just to give a general overview. There's a lot of nuance to this. And so if you have any questions, please put them in the chat. I'm happy to answer them, or also just talk with your child's kidney doctor to see how they're thinking about the stage of your child's kidney disease and what that might mean in terms of medicines or different therapies that are needed. Okay. So that's in general what normal kidney function and structure is. We talked about how we look at measuring kidney function, how we know if it's working or not, the stages of CKD. Now let's move into a little bit more of the meat of this presentation and talking about different types of kidney diseases in children. So how do we know if a child is going to need a kidney transplant, or when do children need kidney transplant? And really that's when one or more of the functions of the kidney aren't working well. And so often when that happens, what we're seeing are things like low eGFR or that advanced stages of CKD. You're seeing electrolyte abnormalities, so some of the ones that we pay really close attention to that tell us a child is headed towards needing a transplant or dialysis would be high potassium, low bicarbonate, which means that the acid level in the blood is pretty high, or low calcium levels. We can sometimes see signs of toxin accumulation. So one of the lab work, one of the labs that will often come back is called a BUN, or a blood urea nitrogen. That's just another toxin that the kidney helps filter that will often get higher and higher as the kidney isn't working so well. And also when toxins accumulate, oftentimes children, they just don't feel so well. They might feel fatigued and have low energy. Their appetite gets low, and those are all reasons for us to start thinking that a child's kidneys are failing. They're having symptoms of that, and we need to do something about that with a transplant or dialysis. Other things that the kidneys, when they don't work, you can see fluid overload and high blood pressure and just poor growth overall. So there are a lot of different diseases that cause kidney disease in children. I put some general categories here. So those are structural abnormalities of the kidneys, genetic and autoimmune diseases, as well as just complications of other organ failures or treatments of other diseases. That I'm going to go into all of those in a little bit more detail. I will say this is by no means comprehensive, that many nephrologists study their whole lives to learn all the different diseases that can affect the kidneys. And I know that there are a lot of parents listening, and so I tried to cover some of the most common ones that I see, but I apologize for any diseases that I have missed. And there are a lot that I've missed. I'm just trying to sort of be a little bit more general. If you ever have questions, though, about why your child specifically has kidney disease or what category that fits in, please talk to your doctor. They'd be really happy to explain it to you. So I want to start. The most common reason that children have kidney failure is because there is some structural abnormality in the kidney that leads to the kidney not working well. And so we've talked already about this picture here in the upper left is what normal kidneys look like. You have two good-sized kidneys that drain into the bladder. And there are a lot of ways that this can go wrong through development. So this picture right below, called a horseshoe kidney, that's one way that the kidneys develop, where the bottom parts of those kidneys fuse together. Most children have no problems with horseshoe kidney. I would not expect that to cause kidney failure by any means. Um, and truly, as long as one kidney is working well in the body, that's all. I would not expect a child to progress to kidney failure. So this third picture here, renal agenesis, which just means a solitary kidney or someone's only born with one kidney, that would be completely fine. I wouldn't expect that to lead to any kidney problems for that child long term, as long as that kidney's working well. But what we see a lot is children who they have both of their kidneys that aren't working well. So like this image here in the upper right, multicystic dysplastic kidney. Having one of those, no problem. But I take care of a lot of children who end up needing kidney transplants because they have two multicystic dysplastic kidneys. Uh, Similarly, um, this picture down here in the middle on the bottom, renal hypoplasia, which means just a small kidney. One small kidney, not a problem if you have a normal size other kidney. And actually, if you have one small kidney, usually the second one gets a little bit bigger. But what can be a problem is if you have a small kidney and the other kidney has a lot of cysts, or if you have two small kidneys, that can cause a lot of problems. I want to talk a little bit too about the one right next to it, vesiculourethral reflux. This is a condition where this ureter, or the tube that connects the kidney to the bladder, can get really big and windy. And the urine, instead of just going straight down from the kidney into the bladder, can start refluxing or moving right back up into the kidney. And that can cause scarring and long-term damage to the kidney. And it becomes a problem where a child may need a kidney transplant, particularly if that's happening in both kidneys. And I'm going to talk a little bit more about this here with posterior urethral valves on this next slide here. So this is an image from the Children's Hospital of Philadelphia. Again, we have the normal kidney here on the left, but in posterior urethral valves, which is a really common condition I see in boys, is that they are born with like some small valves or like a thin membrane here in this part of their urethra, or right between the bladder and the urethra, the tube that brings the urine out into the environment. And when they're born with these little valves, that means urine can't get out of the bladder easily. And so that causes the bladder to get really big and the muscles can get really thick. And then that urine is looking for sort of a pop-off valve or a path of least resistance. So it'll start refluxing up into the kidney. And you can see that this tissue of the kidney here, this parenchyma, or this meaty part, it gets thinned and that the kidney starts to lose function at this point. And with that, especially if this is damaging both kidneys, can lead to the need for a kidney transplant. Now, normally after birth, the urologist will go in and they'll get rid of these valves here, and we'll try to get the urine to come out and watch for kidney recovery. And some little boys will show great recovery, and they just need monitoring throughout their life. However, some will also have pretty severe permanent damage that will eventually progress to kidney failure. All right, so let's move on from talking about some of the structural causes, which is the most common reason that children have advanced kidney disease, and talk about some of these genetic diseases. And there is some overlap. So with this, I want to talk about some cystic kidney diseases. So in children, autosomal recessive polycystic kidney disease, or ARPKD, is more common than the second one I'll talk about, called autosomal dominant, or ADPKD. So in these cystic conditions, there are tons of these little fluid-filled pouches called cysts in the kidneys, and those can really damage the structure of the kidney and ultimately lead to abnormal function. In ARPKD, you need two copies of the abnormal gene. That's what the recessive means, is you need two abnormal copies. And usually this is diagnosed either in utero, so you can even see these cysts in prenatal ultrasounds, or early in childhood. There is some variability in how this presents, but often we're catching this early. Um, and it can cause, because it can cause problems in utero, that can cause babies to have poorly developed lungs and lung disease. And this cystic kidney condition, these cysts can also cause problems in the liver, where you get hepatic fibrosis or scarring of the liver as well. This is a relatively common thing that I see in my kidney clinic, and a reason that some of my patients ultimately need a kidney transplant. Autosomal dominant polycystic kidney disease, or ADPKD, this actually usually doesn't present until adulthood and doesn't cause problems until adulthood, oftentimes reaching kidney failure in the 50s, 60s, even 70s, depending on the type of genetic change. And you only need one copy of an abnormal gene. However, I still see a lot of children with ADPKD. Sometimes they have a known family history of this, so we're watching their kidneys function really closely, um, or it's incidentally found if they're getting an ultrasound for some other reason, or a CT scan for some other reason, and they see cysts, then we may be able to diagnose a child with ADPKD, and we just monitor their kidney function closely. This disease can be associated with brain aneurysms. And so this is something that we will monitor usually in young adulthood. If we're worried, we'll get some brain imaging for that. All right. Another type of kidney disease that can cause kidney failure is something called nephrotic syndrome, and a specific type of nephrotic syndrome called FSGS, or focal segmental glomerulosclerosis. So in children, nephrotic syndrome is one of the more common conditions I see, and the majority of children with nephrotic syndrome actually don't end up having severe kidney disease that lasts into adulthood. They often respond to steroids and don't progress, but there is a subset of patients that don't. And so I'm going to talk a little bit about what nephrotic syndrome is, and how that can lead to kidney failure. So I showed this picture previously showing the microscopic filter units of the kidney called the nephron. And within that nephron, there's this glomerulus, or these tufts, little groupings of small blood vessels that serve as a filter, like a colander that you might use to strain pasta. So in nephrotic syndrome, this filter is too leaky, and so that causes a lot of protein in the urine, which causes low protein in the blood, because it's leaking out into the urine, and then children can get really swollen or puffy because of that. So this is just another picture of that. Normally, this colander, this glomerulus, should be holding in the protein, but in nephrotic syndrome, some of these colorful dots, which represent protein, are leaking out into the urine. And over time, if you're leaking a lot of protein into your urine, that can cause scarring of your kidney and of these glomeruli, and that can ultimately lead to kidney failure if enough of these glomeruli, these filter units, are getting scarred. And so in this image, it's sort of like with the scarring, the holes of the colander are getting clogged up. They don't filter anymore, and that would be the kidney failing. We can see it microscopically, and that's actually FSGS is made. It's a microscopic finding that we see on a kidney biopsy. And in this picture, this blue is representing the scarring here. And so FSGS is just one form of nephrotic syndrome, based on the pattern of scarring that we see on the histology, or on the biopsy. Um, and there are many types of FSGS. Some are genetic, some are not. But we're learning a lot more about one type of genetic FSGS that's caused by abnormalities, two abnormalities in genes called APOL1. And this is particularly common in people of African descent. And so if you have FSGS, or if your doctor notices your child has FSGS, one of the things that we are starting to do more and more is some genetic testing. Okay, moving on, we've talked about cystic genetic diseases, we've talked about FSGS, which can have genetic causes. Another type of genetic kidney disease that can cause kidney failure is called Alport syndrome. And so Alport syndrome also affects those small filter units called the glomeruli in the kidney. And it is particularly a genetic disease that affects collagen. So in those filter units, you have collagen that help form that filter barrier. And if there's abnormality in the function of that collagen, then you can leak blood into the urine. And it can also affect different organs like your eyes and your ears that have collagen in them. And so children with Alport syndrome need to have close attention paid to their vision health and their hearing. Um, Alport syndrome usually doesn't cause kidney failure in children. It really is a spectrum of disease. It can affect males and females differently depending on the inheritance pattern. The more severe type is actually on the X chromosome, and since males only have one X chromosome, they're often affected a little bit more severely than females, though there's a lot of nuance to Alport syndrome. Um, that can predict sort of the severity and when and even if kidney failure will occur. But in males who have the some more severe genetic changes, typically think of them reaching kidney failure around in young adulthood, like 30s, 40s. Though again, there's a lot of variability to that, and certainly some children are affected more severely. And I have cared for children who have had Alport syndrome and needed a kidney transplant for that. All right, moving a little bit past some of the more common genetic causes of kidney disease that I see, and talking about autoimmune disease. So the role of the immune system is to attack invaders of the body like bacteria or fungi or viruses that are not part of your body, and to help your body get rid of them so that you don't get sick. But sometimes there can be abnormalities in the immune system where instead of attacking invaders or things that can make you sick, the body actually starts attacking itself and attacking healthy tissue that it shouldn't be attacking. And there are a lot of autoimmune diseases where the kidney starts attacking the kidney itself. And particularly these glomeruli, you'll see a theme that there's a lot of glomerular kidney disease where those filters are getting attacked. And there are a lot of immune processes that attack those filter units of the kidney. And so some of those are things like lupus, things like ANCA vasculitis, which is an autoimmune disease of the vessels, causing inflammation of the vessels or vasculitis. There are other ones called IgA nephropathy and C3 glomerulopathy. There are a lot of different autoimmune diseases, and the basis really of all of them is you get the body attacking itself, depositing immune complexes in the kidney where they shouldn't be, and causing inflammatory reaction that can ultimately lead to scarring and permanent damage of the kidney, requiring children to need kidney transplants. Okay. Hemolytic uremic syndrome, or HUS, can be autoimmune in the complement-mediated form, but it can also be related to different infections. So there's a type of particularly diarrheal illness that causes bloody diarrhea, usually from E. coli, and it's a toxin that's called Shiga toxin released from E. coli. And that causes really abnormalities in the platelets, which causes your blood vessels your blood cells to start breaking apart, and you get these tiny little clots in the filter units of the kidney. And that can be reversible with treatment, but also sometimes, if severe, it can lead to irreversible scarring and kidney damage. And I've certainly taken care of many children who have needed a kidney transplant because of HUS, either related to an infection, or because of an autoimmune or complement, what we call complement mediated process. And some of these complement mediated or the autoimmune version can be genetic. And so we'll often do genetic testing in these cases. There are a lot of really great treatments to help prevent the progression of kidney disease and control this. And so I think this used to be more severe in the past, and we're getting a little bit better at treating it now. And then finally, we've talked about structural abnormalities, we've talked about genetic and autoimmune diseases. The kidneys can also sometimes be innocent bystanders that get harmed because of other diseases that are happening in the body. So one example of that would be heart failure. So the kidney needs the heart to be working well to get the blood pumped to the kidney so that the kidney can work and clear toxins from the blood and do its job. If the heart isn't pumping well, sometimes for many reasons, children may have a cardiac arrest if they're really sick, or they may be born with abnormal hearts, and that heart doesn't pump normally, the kidneys can be injured from that. And if severe over a long enough period of time, that could cause kidney failure requiring a transplant. Similarly, there are different liver diseases that cause the blood to sort of be shunted away from the kidney. And so if the liver disease continues and the blood shunts away from the kidney, you can get chronic kidney disease that can progress. And then finally, there are a lot of different diseases like cancers that you treat with chemotherapy. And those chemotherapy, while it's necessary to kill the cancer, it can be toxic to the kidney and cause damage over the long term. Um, and all of this can also sometimes be worsened when babies are born prematurely. So kidneys stop developing around 36 weeks. And so babies who are born much earlier than that, their kidneys might not have as many of those filter units, as many of those nephrons. And so you add any of these diseases or any heart problems with prematurity, and that's kind of a tough combination for a lot of babies that they may have chronic kidney disease and need a kidney doctor to watch their function as they grow. All right. So let's move on from talking about kidney diseases to what just broad overview, what does a transplant evaluation look like? So it's really important to note that transplant is one form of a kidney replacement therapy. So transplant is one thing that we can do. It is a treatment. It is not a cure to kidney disease. Um, so different ways we can do the job of the kidneys with dialysis and transplant. I know you've had other talks on dialysis, so I'm going to focus on transplant here for a second. Kidney transplant is our preferred form of kidney replacement therapy. Children who are transplanted, they don't need to be reliant on a dialysis machine to keep them alive. We notice that they grow better, they develop better, they can go to school more easily when they're transplanted compared to when they need dialysis. But a transplant is not a permanent cure. Most transplanted kidneys will last about 10 to 15 years. Now, there are a lot of examples of kidneys that have lasted much longer than that, and there are also children who receive transplants that last much less time than that. But usually a transplanted kidney isn't forever, and it's something we watch really closely. And most children who have chronic kidney disease will actually need more than one transplant in their life. And this first transplant usually lasts the longest. And so when we're giving a transplanted kidney to a child, we take especially close care at the beginning to make sure it's the best kidney that we can give them to make that kidney last as long as possible. And so the evaluation can become really tiresome and burdensome. There are a lot of checkpoints, and the reason for that is because we just want to give the child the best chance to get the best kidney that they have and to be as safe and healthy when they're getting that kidney. So I'm just going to go through this process here. Up in the upper left, we have a child who has kidney disease that is advanced and needs a kidney. And so some of the ways that that child can get to the kidney is by going through this evaluation process. So first they need to grow. Most pediatric transplant centers won't transplant a child less than 10 kilos, which is about 22 pounds, just because we have to fit usually an adult-sized kidney into a child's abdomen and their body. And so we need them to grow big enough so that will all fit. And so after the child is grown, big enough and has enough weight, then we'll start more thoroughly going through the different steps of the transplant evaluation. So that means meeting with a kidney doctor who's a specialist in transplant, meeting with a surgeon. You're usually meeting with social workers, with psychologists, and with the pharmacists, as well as potentially many other people who are part of the transplant team. And I just want to highlight how important the social worker is in all of this. Um, the, Insurance can be really tricky for children with chronic kidney disease, particularly with dialysis and transplant. And many children will have multiple forms of insurance. They might have private insurance and Medicare and maybe even Medicaid. And while all those insurances help ensure that all the services the child needs should be covered, it can also sometimes make it really complicated when the different insurance agencies fight with each other about who should cover what. And so social workers are a really important part of the transplant evaluation team um, in helping manage some of the complications of the insurance. Okay, so the child grows, they meet with a whole bunch of people who are part of the transplant evaluation team. They'll often need some additional labs and imaging. They're looking at many different things such as blood type, kidney function, as well as other markers that can help us decide if a kidney would be a good match. So things called like HLA or and then the child may also need some other subspecialty clearance. So that's meeting with urology to make sure that the bladder looks good and healthy enough to connect another kidney to it. Or a child may need to meet with a cardiologist to make sure their heart is healthy for a kidney. And so the transplant team will tell you which other specialists you may need to meet for before the child's eligible to receive a kidney. Now, at the same time, if there is an adult donor who is interested in donating their kidney, and it's important to know that a living donor needs to be an adult. We don't accept kidneys from children to other children. That adult donor will also have to go through their own evaluation process. And so that looks like a whole separate process, and usually they're separate teams that are caring. One team is caring for the child and another team is caring for the donor. And that way each team has the best interest of either the child or donor, and they make sure that the donor would be truly safe and not coerced into donating a kidney. And so the donor has to go through their own evaluation, meeting with kidney doctors and surgeons and social workers and psychologists and similar evaluation. They have to get labs and imaging. Many of them will make sure that the adult's kidney structurally looks normal and that the function is good and they are healthy enough to donate. The donor needs to make sure that they're up to date on all their routine health maintenance, so that they're a healthy weight, that if they need a colonoscopy or a mammogram, those things are all up to date to make sure the donor is as healthy and ready as possible to give a kidney if that's what they choose to do. And then that donor may also need their own subspecialty clearance, meeting with heart doctors or endocrinologists or geneticists to make sure that they're safe to donate their kidney. Now, if it's deemed that that donor is safe to give their kidney, they can either directly give it to the child if they're a good match, or for many reasons, sometimes the adult donor may not be a good match for the child, but they could be a good match for another person who needs a kidney. So that donor would give their kidney to someone else who needs it. And then that other person may have a family member or a friend who's a good match for the child. And then that person gives their kidney indirectly to the child. And then finally, while we prefer living donor kidneys, there are many reasons that that may not be an option or may not be safe for a family to go through with. And so if that's the case, a child can also receive a kidney from a deceased donor, which is someone who's agreed to give their kidneys or give their organs after they die. And for that process, there's a wait list that you may be a little more familiar with or have heard of before. So there are a lot of factors that affect how long a child needs to wait for a kidney. One of those is just the availability of a living donor. So if there's an available donor who can move through that process in a timely way, that often means less waiting time for a kidney for the child. There are certain blood types that are easier and others that are more difficult to match with. So blood type B is usually a harder blood type. It's just a little bit less common. So to find a match, children with B blood type will often wait longer. There's also something called sensitization, which is which is If a child has received other blood products before, sometimes they're exposed to different antibodies that may make it more likely for their body to reject a donated kidney. And so when we're doing matching, we're not only looking at blood type, but also all of these other factors that may cause a child to reject the kidney. And someone who's received a lot of blood products before, it might just take us a little bit longer to find a good kidney that their body is less likely to reject. Disease activity is really important. So there are many diseases that can recur in the kidney, particularly many of those autoimmune diseases that I talked about. So things like lupus or ANCA vasculitis, C3 glomerulopathies, those can recur in the transplanted kidney. And so before we're putting a new kidney in a child, we want to make sure that those diseases are well controlled to minimize the risk of them recurring and reoccurring quickly in that transplanted kidney. And so if there's still a lot of activity, disease activity going on in the child, it may mean they need to wait longer for a kidney transplant. And then finally, a lot of this also comes down to there are a lot of things to check off and a lot of specialists to see, and just the evaluation process, both for the child and if there's an interested donor, can take a while. And so the speed through which you can move through the evaluation process can affect how long a child has to wait. And really, the importance of having good support can be really key in overcoming all of the barriers to finishing that evaluation. That said, children get special priority on the wait list. So about half of the pediatric transplant patients, from the time that the evaluation team says, okay, we're going to actively list you, meaning we are going to start accepting offers for you to receive a kidney or for your child to receive a kidney, usually about half of them will wait less than a year. But again, it's affected by all of these many different factors that we're weighing. And these wait times are less for children than for adults because of the special priority that they get. So strategies to minimize wait times for a kidney: start conversations with family and friends about looking for potential living donors early. I know that these conversations can sometimes be hard to have, but we have a lot of different strategies and support that if this is something you're interested in looking for living donors, talk to your child's transplant team. They'd be very happy to help advocate for your child and work through how to have these conversations. You want to make sure that your child's immunizations are up to date. Many immunizations, like live vaccines, can't be given after transplant because of immunosuppression that the child receives. So it's really important that they are entirely up to date before transplant. And many immunizations are series. So you get one and then you have to wait a period of time before you can get another one. And so making sure that you keep up on your child's vaccines, and these are all up to date leading up to the time of transplant, is really important. And children with kidney disease often receive some extra vaccines, particularly extra pneumonia vaccines. Other things, making sure routine dental care and vision care is up to date. Those are all things that your transplant team are going to want to see before they give the okay to move forward with transplants. And then planning for a lot of appointments, which can be really burdensome in terms of time away from work, or making sure that you have childcare for your other children. And so having peer support can be really important, part of successfully navigating through caring for a child with advanced kidney disease and who may need a transplant. So to summarize, we talked that the kidney has a lot of really important functions, but mainly it is filtering and cleaning the blood. There are a lot of different ways that we look to see if the kidney is working, and one of the common ways that we use is called eGFR, which is based off of a blood value called creatinine, as well as other characteristics like age and height and sex of the child. And we use that eGFR to define a child's stage of chronic kidney disease. Um, there are a lot of different causes of kidney disease that range from structural, genetic, autoimmune, and then just complications of other organs not working, or treatments for cancer or other diseases that can be damaging to the kidney. But in children, structural causes are the most common, especially if you have two kidneys that aren't working. If you have one kidney that works well, you're in good shape. But if both kidneys have something wrong with them, that's when you can get pretty significant kidney disease. And finally, the kidney transplant evaluation has a lot of steps, and a lot of families benefit from peer support. So I'm so happy that you're here as part of transplant families and their conference. I really rely on them. There are also a lot of other organizations like the National Kidney Foundation. There are different disease-specific organizations that look to provide families with support because it can be really scary and challenging and isolating to navigate. Here are some references that where I received some of the pictures and information that I presented today. And I just want to say thank you so much for listening, and I'd be really happy to take any additional questions that you have at this time. Thank you so much, everybody, for joining and for all the great questions you've been sending in. I've been trying to keep up as we go. I'm just going to pull up some of the questions that I've saved for our live time here. I'm going to hope to get through all of them. And if I don't, I'm happy to reach out to the coordinators to make sure I can answer all the questions that have come through. So one of the first questions I wanted to answer was, what does the eGFR need to be to show no kidney disease? So it's a tricky question. So technically, a GFR greater than 90 is considered normal. However, someone can have a GFR greater than 90 and still have CKD stage 1. So the classic example of this would be someone who's born with one single kidney, and that one single kidney is working great, but structurally they have abnormalities in their kidney. So we would say they have CKD stage 1, presuming the GFR is above 90, but a function with the GFR above 90 is considered normal. Okay. The next question is, how does a pediatric kidney transplant differ from an adult one? There are many ways, but I would say one of the biggest ways is that we just need to make sure that the child grows. And in adults, you typically have a full-size human being, where in kids, we're often delaying, especially in those babies and really little ones, when we can give them a kidney because they have to grow. They usually have to be at least 10 kilos. And then not only is it weight, but also height, because they have to be tall enough to fit an adult-sized kidney in their little body. And so also children with kidney disease have a hard time growing. So we use growth hormones and other things. So I'd say that's a big one, is that kidney transplant in younger children can be delayed. Another thing that I think comes to mind readily is that many children who have advanced kidney disease are going to need more than one kidney transplant in their life, depending on how long that kidney lasts. And so we really want to make sure that that kidney that they're getting is a good one. So we usually only accept from younger donors. We want to make sure that the match is good and those types of things. We try to avoid, there's different practices at different centers, but in general, sometimes adults will accept like a kidney from a hepatitis C donor because we have okay treatments for that now. We usually don't do that in children. And so there are a lot of different ways in how we're being a little bit more selective about the kidneys we pick for children. And then I would also just add that in children, there are a lot of other social considerations, school and friends and development, that we're thinking about. And children who need a kidney transplant and they don't have a living donor, they actually get extra priority on the deceased donor list to try to get extra priority over adults who need kidneys. Because we just recognize that kidney disease can be really detrimental to children's development and growth and all these things. All right. What should families do to help prepare themselves when their child is on the wait list? That's a really great question. I think one of the most important things that comes to mind is recognizing that this is going to be a marathon. It's not a sprint. And there are probably going to be, just mentally preparing that there are probably going to be times where a lot of things are happening all at once. There are a lot of appointments, a lot of things to do, and then there's going to be a lot of just waiting time too. And so just mentally preparing for the ebbs and flows, I think, is a really important thing. Practically, I think if you feel comfortable and are interested in having your child receive a living donor, talking to family and friends about this early is really important and can be a tangible thing that you can work on. It's always easier to start planting seeds early than when things are in crisis or if there are a lot of things going on all at once. So that would be something I encourage people to do early. But then just spend time with your children. Like, make sure they have as normal of a childhood as we can with chronic kidney disease. Spend time outside. If they're able to go to school, get them in school. I always tell my families that kidney disease is a part of life, but it should not be the whole life. And so um, if there are any follow-ups, I'm not sure if I'm targeting exactly what that question asker was asking, but I'd say mentally prepare. It's a marathon, not a sprint. See if you can find donors early, and then just enjoy your time with your kids. Let them have as normal of a childhood as possible without the kidney disease taking over the whole thing. What are some things that surprise families about kidney transplants? I like this question. So the question asker had put in their question things like the non-working native kidney is sometimes left in place, which is true. So for many diseases, there are exceptions, but in general, when kidneys stop working, we don't take them out. And so a child who's received a kidney transplant many times will have 3 kidneys. And then if that kidney stops working, then they might just put another kidney in and you get 4 kidneys. And so I do think that's a common surprise. Another one that I think can surprise people sometimes with how organ transplantation is portrayed in the media is that it's a cure. So if you just get to kidney transplant, that cures the kidney disease. And while it is a life-changing gift to have a kidney transplant, it unfortunately is not a cure. And I find many families are surprised by the fact that children will need more than one kidney transplant in their life, usually. Those are the big surprises that come to my mind right now. I'll keep thinking, and if something else comes up, I'll jump in. All right. Can you speak more about the donor swap program? So that'd be, there are different ones through religious organizations, as well as the National Kidney Registry, or NKR is a common one. And so this question asker, thank you, shares that her daughter's 8 years post-transplant. And so the question is, if a parent or caregiver were to join a donor swap for her future, would that transition to future adult care if she needs a second transplant later on as an adult? The short answer is I think so. Definitely, we do have donors who donate in advance. So in particular, I've taken care of families like, say, a parent wants to donate but isn't a blood match with their child, a blood type match. They might donate their kidney a year or so before their child needs a transplant, and that actually almost makes it a little bit nicer when the child does need the transplant, that it's just caring for the child and not for the donor in the family as well. The caveat and why I say I think so, not I know so, is because I'm not sure how long the vouchers last and if there's an expiration to them. So I would encourage you chat with your transplant center, your nephrologist. That's something that can be found out easily if there's a particular registry or exchange program you're interested in, and they can get you more details about each particular registry. Oh, I started typing an answer to this question before I joined live, but would you advise that a child being listed at more than one transplant center? So I started typing. That's a tough question. I think it really depends. If the transplant centers are close to each other in distance, then you're probably not, because the donors, the kidneys are allocated based on how many nautical miles they are away from a center right now. And so if you're going to 2 centers that are pretty close to each other in location, you're probably not expanding your donor pool all that much. I would say that transplant centers have to post their outcomes. And so if you're at a transplant center that has better or worse outcomes than another one, that would be something to consider. It might be beneficial to look at more than one transplant center. And I'd say too, you just want to have a degree of trust and good communication with the transplant center where you are, because your child's going to be receiving some very intensive care from them. And so if you feel that you're not getting that where you are, it might be beneficial to look elsewhere. However, if you feel like you are getting good care and they have good outcomes, and it's not really feasible if you're on the deceased donor list to fly many miles away or drive many miles away, it probably isn't all that beneficial to go to more than one transplant center. So I'd say in general, no, but it also depends on the transplant center's outcome and distance from where you are. All right. And then would you consider a DCD donor for children? So that's a deep ethical question. I think that so donation after cardiac, I guess actually, I don't know if the person who's asking can clarify. Are you talking about just donation after cardiac death or some of the newer technologies that are being used to like keep blood perfusing through the organs sooner? I guess I'm not fully following that. But in general, it really depends. I'll just talk generally that maybe every kidney that we consider, we have to think about the death after circulatory death. I would say I would consider it. But in general, one of the most important factors for the longevity of a kidney is the ischemic time. So how long blood hasn't been perfusing well through the kidney. And in children, like I said, we're very picky about the kidneys that we get. We want to get really good ones because many kids will need multiple kidney transplants in their lives. And so if the downtime, if the ischemic time was really long after circulatory death, depending on the circumstances, I likely wouldn't accept that. But it would really, really depend on the circumstance and also how the child is doing. Because if the child is really sick and not doing well on dialysis, that might be another reason to push us to take a kidney that we otherwise might not consider. Thank you for clarifying, Rebecca. Okay, and then there was one other question. Let's see if I have time. I have 4 minutes. There was another question that I was hoping. There's a question about matching. Can you explain the matching process? And does a kidney need to be a perfect match to be long lasting? So the matching is based on many things. So blood type is, you need to be compatible blood type at the most basic level. But then there are many other immune markers and HLAs that we look at to find good matches. And I would say that in general, no, you definitely do not need to be a perfect match to have a great kidney that lasts a really long time. And in fact, there are some diseases that we prefer not to get too close of a match, or at least a match within the family, because we have found worse outcomes with certain disease. So like atypical HUS or complement-mediated HUS is a disease that comes to mind where that's the circumstance. But no, it doesn't need to be a close match. And different institutions actually do matching differently. Blood type is very standard, but we have different immunologic and HLA labs that are looking at many different markers. And so we try to get the best match that we can for the children in the diseases that we, in most all cases, with a few exceptions. Great. I don't know. Did I miss any questions that I can help with in the last few moments, if any of the organizers are looking? Okay. Well, thank you all. I have to say, Transplant Families is incredible. I'm so grateful for the opportunity to be a part of this great conference you have today. And I'm really inspired, most of all by the families who take care of children with kidney disease and children who need transplants. You all are amazing. And you inspire me and make my job so wonderful to go to every day to get to meet and interact with such great transplant families. So thank you again. Feel free to the organizers to share my information. If there's anything I can help with in the future, let me know.